my colleague, Dr. Maisa Amir. She's a certified diabetologist and background of family physician. That means she get what you call a double major. We give her, in fact, Dr. Abdelghani give her heart topic, which is inpatient management of hyperglycemia. Since I can judge that more than 50% who have been admitted to the hospitals, they have type 2 diabetes mellitus / type 1. So Dr. Mesa will talk about how to manage this patient. Again, time only 20 minutes, but I'm sure she can fix the time and the talk. Mesa, go ahead.
Good evening, everyone. Thank you very much, Dr. Douish. Thank you for the opportunity, and Dr. Abdelghani also. Actually, in fact, the topic, as you said, is really a bulky topic, and I would try my best to go through at least the important slides, and I hope everyone will benefit from them, inshallah. Okay, first, okay, hold on. Okay, there are guidelines or the objectives I'm going to talk about, goals of patient management. Then we're going to talk about target blood glucose levels, insulin delivery, and dose of for patients, either if they were eating or there were total parenteral nutrition, and oral versus insulin use for inpatients. Okay. Goals of management. As inpatients, usually we have to keep in mind in their management as diabetics and inpatient, we should always treat the hyperglycemia that they're facing, but also we should keep in mind that we should avoid getting them into hypoglycemia. Also, we should also keep in mind that these patients are ensured adequate nutrition, and also we should keep them blood sugar controlled as inpatient and discharge them with good blood sugar control, and keep in mind that they should be given to an outpatient clinic to maintain this blood sugar control, and also to assess the patient's educational needs and address their deficiencies. So why do we keep in mind to always avoid hypoglycemia? As you know, hypoglycemia, which is the blood sugar level of less than or equal to 70 milligram per deciliter, it's a very harmful effect due to the counter-regulatory hormones, especially the catecholamines, which may possibly induce arrhythmias and other symptoms that might be very harmful in elderly patients with pre-existing ischemic heart disease. Also, the hospitalized patients, they are also vulnerable to severe prolonged hypoglycemia, since they may be unable to sense or respond to the warning signs and symptoms of low blood sugar. Also, it's very important to avoid hyperglycemia in patients, as poorly controlled diabetics are more susceptible to infections. Also, the immune system and neutrophil functions are impaired during marked hyperglycemia. Also, the hyperglycemia can cause volume and electrolyte disturbance with the osmotic diuresis effect, result in caloric and protein loss in under-insulinized patients, which can be harmful for ill patients. So as I mentioned, it's important to treat and avoid hyperglycemia, but also take care not getting these patients into hypoglycemia. Regarding the glycemic targets for inpatients, there are lots of guidelines, but I will talk about mainly two guidelines, the ADA and the Endocrine Society. As the ADA, they suggested the glucose target between 140 to 180 milligram per deciliter for general hospitalized patients. Also, we can put patients on more tight goals, 110 to 140, and only selected patients if we are sure that these patients are not at high risk to develop hypoglycemia. Also, the Endocrine Society, they put the target for pre-meal target less than 140 milligram per deciliter and random glucose of less than 180 milligram. Also, more tight goals can be for selected patients, and goals should be higher for older patients with severe comorbidities and with the high risk to develop hypoglycemia. These scheduled, you can see different guidelines, the ADA, American College of Physicians, Endocrine Society, putting different guidelines for patients in the ICU and patients who are not in the ICU. This is a study that was published in 2009. It is the NICE sugar study, which they compared the intensive versus conventional glucose control in critically ill patients. They wanted to see which was better, intensive control blood sugar, tight control, or the normal conventional control that was the target that's set. It concluded that intensive control increased mortality among adults in the ICU. So a blood glucose target of 180 milligram or less resulted in lower mortality than tight control. So in patients, usually they're classified into three types of category. Either they are patients type 2, type 1, or patients receiving enteral or parenteral feeding. So patients type 2, they're either on diabetic diet, or they're using oral anti-hyperglycemic agents, or they're on insulin. Patients type 2 on insulin are usually managed and approached the same way or similarly as patients type 1 who are totally insulin dependent. Some circumstances where insulin may not be very necessary, when can we keep these patients on their oral medication? Well, if the patient at home was controlled on his oral medication and he's admitted, that means we can continue this oral medication. If the patient was allowed to eat normally in the hospital as 3 meals and not required to be NPO or fasting, he can continue the oral medication. If there were no change in his medical condition, he's not worsening and he is not that sick, he can continue his oral medication. And also if there were not any contraindication to these oral medications, such for example, if the patient is expected to go undergo IV contrast for any investigations, or that, for example, metformin is contraindicated, so should be stopped. Otherwise, they can be kept on their oral medications. As I mentioned, metformin is contraindicated even if the patient has renal function impairment or hemodynamically impairment. Metformin can put the patient in high risk to develop lactic acidosis. These are some of the oral medications. For example, the pioglitazone should be avoided in patients with heart failure because it has high side effect of peripheral edema. The sulfonylureas, they are secretagogues that stimulate secretion of insulin and they have a long duration of action. So if they're given to inpatients and these patients are not eating well or they're suddenly put for fasting or decreased appetite, they can put the patient into high risk of hypoglycemia. I'll try to just mention the most important stuff because I don't want to take more time because I have more important slides coming up. The DDB inhibitors, such as sitagliptin, linagliptin, these medications usually they're effective in postprandial settings. So they have no role in patients who are not eating, and also they have not been tested sufficiently in critically ill patients. So there are only some studies are done in patients such as this study, which is the CETA hospital study. It was done for efficacy of sitagliptin for hospital management of general medicine and surgery patient of type 2. It was done not in the critically ill patients, 2017. Patients were put into two groups. The first group was sitagliptin plus basal insulin. The other group were basal bolus, the normal basal bolus insulins. And they monitored the blood sugar throughout the day in the hospital, through the hospital stay. It concluded that sitagliptin plus basal insulin is as effective and safe and can be an alternative to basal bolus, such as the basal insulin and short-acting insulin, but not in the intensive care unit, not in the intensive care settings. GLP-1 also it's not usually used as inpatient because it has used in postprandial glucose control, and also there's a side effect, the nausea, which is not a pleasant side effect for sick patients. SGLT2s such as DAPA, CANA, they work by a renal excretion of glucose. They promote the renal excretion of glucose. So there's a high risk of dehydration, genitourinary tract infection, euglycemic diabetic ketoacidosis in type 2 and type 1 diabetics. So these drugs should therefore be not used in patients in the hospital settings. Okay, now I'm going to talk briefly on how to approach patients how to approach the blood sugar for inpatients, whether they're type 2 or type 1. Type 2 and type 1, they're similar in the insulin doses. So when I'm talking about insulin in type 2, just keep in mind that's usually similar to type 1, and I will mention what are the differences. So patients, type 2, inpatients, there are two types. They're either on normal diet or they're NPO. If they were on normal diet and the blood sugar was well controlled at home and they came to the hospital and they're eating well, we can continue, as I mentioned before, the oral medication, but just to decrease some of the secretagogues, such as the sulfonylureas, because of the hospital, they have more strict diet and their appetite is not as same as their home. If they are admitted and they're poorly controlled on their home medication, then they should be put on basal insulin with these doses to calculate either NPH twice a day, Detemir once a day, or Glargine, and put them on bolus insulin before each meal that they eat, and correction doses just to maintain and to fix their blood sugar. If that was the initial dose that you put for these patients is not enough and not controlling the blood sugar, then we can adjust these doses. For example, the basal insulin, we adjust by 10 to 20% every 2 to 3 days. The prandial insulin, 1 to 2 units every 1 to 2 days. Also, the correction dose is corrected. When do we consider putting these patients on insulin infusion? If the blood sugar was markedly elevated, more than 300 to 350 milligram per deciliter, or if these patients were expected not to eat well after surgical procedures. So we can put these patients on insulin infusion to control their blood sugar. What if these patients, and they're NPO, they're expected to be fasting or they cannot eat in the hospital? First of all, we discontinue all of the oral medication and put them, if the blood sugar at home was controlled, put them on correction doses every 4 hours if we're using, for example, glutazine or aspart, and every 6 hours if they're using regular insulin. If the blood sugar if it's not controlled, then we put these patients on basal insulin, and then every 6 to or 4 hours, depending on the type of insulin, we give them correction doses to maintain their blood sugar or to control it. And as I mentioned previously, when to put these patients, consider insulin infusion. If the blood sugar was markedly elevated, these patients need insulin infusion to control their blood sugar. And if they were expected to have decreased oral intake for several days, then insulin infusion is required, or we can put them on basal insulin plus correction doses every 6 to 4 hours to maintain the blood sugar control. So that's if these patients were type 2. What about if they're type 1? Basically, it's the same when we're talking about insulin. But type 1 patient, the most important that if they're controlled on their insulins at home, when they're admitted, put them on their same doses, but decrease of the doses by 25 to 50% due to the change of appetite and the more strict nutritional food in the hospital. The same door, if they're on diet, we put them on basal bolus correction. Just keep in mind that patients type 1 who's undergoing a difficult or major surgery, these might, and we want to control the blood sugar, it's not controlled, we can put them on insulin infusion for a couple of days until their blood sugar is controlled. Okay, these two studies were interesting. The DEAN trial, what they compared managing inpatients who are not in the ICU. They wanted to compare which is better to use, basal bolus insulin or NPH and regular, which is better to be used, which has better outcomes. So they put these two patients in two groups. They monitored their blood sugar towards their hospital stay. They concluded that similar glycemic control and hypoglycemic outcomes in hospitalized patients, if they're type 2 patients, whether we use basal bolus or NPH regular. So we can choose either depending on the patient situation, depending which is more convenient for the patient. Another trial that's interesting, the RAPID-2 surgery trial, it was done on surgical patients. They compared basal bolus insulin in surgical patients post-operatively, comparing to sliding scale of regular insulin, which is checking the blood sugar every 6 hours and giving insulin according to the blood sugar reading. So which was more beneficial? So post-operatively, they compared the purple line is the basal bolus and the green lines are the sliding scale. As you can see, the patients who were on sliding scale had more wound infections and they were more prone to pneumonia and acute renal failure. So they concluded the study that basal bolus insulin is more improvement in glycemic control in surgical patients post-operatively compared with patients on sliding scale. Okay, we're just reaching the end of the presentation, hopefully. Hyperglycemia, how to approach patients, hyperglycemic patient, if they're on enteral feeding, nasogastric tube, TPN, whether they're type 1 or type 2 patients. So we have different types of feedings. These are the standard formulas and these are the diabetic formulas. On each formula in the hospitals, you can find the carb content, fat, protein. So this will help us in how to calculate the insulin needed for these patients by doing the carb count and such thing. This is a very nice table that summarizes everything. It's found in the ADA. So the enteral feeding, it's either the type of feeding, it's continuous feeding or bolus feeding, or it's parenteral feeding. If the patient was on continuous enteral feeding, what we do is we put him on basal insulin, regardless which type of basal insulin, is it NPH or degludec or glargine. And then depending on the insulin that you're using, it's either aspart or regular insulin. If aspart, every 4 hours, we check the blood sugar and give them a dose that's according to the reading. But if the patient was on bolus enteral feeding, we should also keep him on basal, as I mentioned before, and put him on nutritional insulin with every feeding. We check the blood sugar and give him insulin according 1 unit per 10 to 15 grams of carb in the formula that they're using. If the patient was on parenteral feeding, we add the regular insulin to the TPN solution, starting with 1 unit per 10 grams of carb. It's a nice here, 2 approaches to do that. First, we put the separate infusion of regular insulin, can be used, and then we keep the patient on this infusion until the blood sugar is controlled. We calculate the total daily dose, and then 80% of that dose is added to the TPN fluid infusion and delivered over 24 hours. Another approach is doing the same, putting the patient on separate regular insulin infusion, and then when the blood glucose is controlled, we calculate the total daily dose, and then 50% of that dose is added to the TPN fluid, and 50% of the amount is delivered via basal insulin injection. So there are 2 approaches. The risk of the first approach is that there's a high risk for type 1 patients, because in case of the TPN is stopped, the patient is deprived of insulin from his body. So that's more risk of developing DKA. So the best thing about the second approach is even in type 1 patients, if the insulin or the TPN fluid is stopped by any means, the patient would still have basal insulin in his system that can protect him from developing DKA. So I hope that we have talked about all the goals and how to approach them. And I hope that it didn't take much time. Thank you very much for listening. Is there any questions?
Sure. Thank you, Maisa. It's really an elegant talk, practical talk, to be honest, which is what we need in our...
I tried to just make it practical and as short as I could. There are a lot of different situations. And just one thing, managing inpatients should be tailored to each patient separately. We cannot put the idea that one rule fits all.
Absolutely. For the question, we'll have Q&A at the end of our tonight's session, for all the panelists, whether it will be verbally or they can write in the Q&A setting. Thank you again, Maisa. Our fourth speaker, my colleague, Dr. Wael Zahrani, is a consultant endocrinologist. Also, he's in our department. He's interested in giving talk. Also, he loves to give teaching for our colleague in medical department, giving in their courses, preparing their final exams. Wael will present today about acute hypocalcemia management. Wael, go ahead.
شكرا يا دكتور محمد. Thanks to give me this opportunity, and thanks Dr. Abdelghani. Also, we thank Dr. Balsam and Dr. Mesa for their nice presentation. Our talk will be, inshallah, about hypocalcemia, mainly acute hypocalcemia. We will start with the introduction of calcium as one of the anions in our body. It's regulated in a narrow range, usually by vitamin D and parathyroid hormone, through their action on the bones and intestine and kidneys. And the calcium usually it's in three situations in our body as a chemical states. 50% of it is as free ionized calcium, and 40% as bound to plasma protein, mainly albumin, and 10% as diffusible ions with inorganic or organic bicarbonate or lactate or phosphates. The majority of this calcium, it is stored in our bones as 99%. The rest of it as 1% is as extracellular fluid and soft tissues. As the incidence or prevalence of hypocalcemia, it's common electrolyte disturbance. Usually it's reach 26% in hospital admission patients, and up to 88% in critically ill patients in ICU. As a definition for the normal range of calcium, as you mentioned, usually it is in narrow range. Total calcium should be from 2.1 to 2.6, and the free ionized calcium from 1.17 to 1.33. Any level below this will be defined as hypocalcemia, and the total calcium usually should be corrected by albumin as the protein binding for calcium. Most of our labs here give you already the adjusted calcium, but the calculation you can do it in an easy way. Each 1 gram per liter of albumin reduced, that means you need to adjust the calcium by 0.02 as upward. For the etiology of hypocalcemia, it's a long list of causes, but let's say that the most common cause of chronic hypocalcemia is vitamin D deficiency. And if we talk about acute hypocalcemia, the most common cause is the post-operative hypoparathyroidism after the head and neck surgery, usually total thyroidectomy or parathyroidectomy. The list of etiology we can divide it either by parathyroid hormone related and non-parathyroid hormone related, or by this schedule here as reduced entry of calcium or increased movement of calcium out of the circulation. Either way you like. The most common is the parathyroid hormone dysfunction, as hypoparathyroidism as autoimmune or post-surgical, or congenital causes like a DiGeorge syndrome, vitamin D deficiency as malabsorption or secondary to other organ failure, reducing bone resorption, usually secondary to osteoporosis medication like bisphosphonate and denosumab. The causes of making the calcium out of our circulation, we can the usual and the common cause of it is the hungry bone syndrome, which is after the surgical parathyroidectomy, and the other cause of end organ damage, either renal or liver dysfunction. Also, we can consider the acute pancreatitis and the sepsis in ICU situation and admission patients. It's the same causes, but with a different way of distribution. To diagnose the hypocalcemia, once you have this situation, you should go for workup and labs to know the underlying cause. Usually there is there is a routine investigation, common labs, you need to do it initially. And there is a specific investigation for the underlying cause. Routinely, we need to confirm the hypocalcemia, either ionized or corrected. You need to check the parathyroid hormone and magnesium level and renal function, and the bicarbonate level for the acidemia, and the ECG to confirm the finding of hypocalcemia. In this algorithm, let's go just down here for the interpretation of the labs that you ordered already. So in case of low parathyroid hormone and high phosphates, that's mean we are talking about hypoparathyroidism mainly, either because of the resistance secondary to hypomagnesemia or drug, or of the permanent hypopara, like post-surgical or autoimmune. If both of them, the parathyroid hormone and the phosphate is high, so usually this presentation of chronic kidney disease cause of hypocalcemia. And for the last presentation of high parathyroid hormone and low phosphorus, that's mean the commonest is vitamin D deficiency. It can be medication or acute pancreatitis with this situation of labs. For the clinical assessment of hypocalcemia, it is important because it will affect your approach and judgment of the treatment to identify if the patient is symptomatic or not symptomatic. The severity and of the sign and symptoms, it's depend on the level of calcium, how low it is, and also the rapidity of the onset of the decrease of the calcium. Most of the clinical manifestation is neuromuscular dysfunction. We will go through it. We can give two examples just to make it clear for the symptoms, like in post-surgical setting. That's usually we have dramatically drop of calcium, so it's mean will be symptomatic and need aggressive intervention. In the opposite, if you have patient with chronic hypocalcemia, like for hypoparathyroidism, usually they can be even asymptomatic despite the level of the calcium. So as we say, most of the features of hypocalcemia is neuromuscular manifestation. This schedule can help us to even differentiate between the feature of acute and chronic hypocalcemia. We will go one by one to the symptoms of acute hypocalcemia in comparison to the chronic. The earliest sign of the hypocalcemia is the perioral numbness and acral paresthesia. Usually, this is the first sign to be complained by the patients. If it is more severe, the level of calcium go down, you will find the carbopedial spasm, and which is may stay for a few minutes, and in the most severe cases, it may be also cause life-threatening laryngospasm. We have, as everyone knows, there is two signs of hypocalcemia in clinical situation. The first one is the chiastic sign, which is ipsilateral twitching of the facial muscle. It's of the perioral, nasal, and ocular region. Once you tap over the facial nerve around 2 centimeters anterior to the ear lobe beneath the zygomatic bone. But the problem with this sign, it is not specific. It's happened in 25% of the normal individual, and also can be absent in patient with hypocalcemia in around 30% of the hypocalcemia patients. The more specific sign is the Trousseau sign. It's typically the deformity as in the picture here. It is flexion of the wrists and metacarbopharyngeal joints, hyperextension of the fingers, and flexion of the thumb. As we say, it is more specific. You can elicit it by occluding the brachial artery around 20 millimeter of mercury above the systolic pressure for 3 minutes, and for 3 minutes, and is positive in only 1% of normal calcemic patients. So yeah, we can depend on this sign more. Neurological manifestation other than that we mentioned, we have irritability, confusion, and seizure. And in non-epilepsy patient, hypocalcemia can lower the threshold for the seizure activity. As feature of chronic hypocalcemia, it can be neurologically as depression, dementia, or extrapyramidal feature. But again, patients who present with acute on top of chronic hypocalcemia can exhibit both sets of feature. The other feature of hypocalcemia can be cardiac, which include the changes of the ECG and cardiac failure. The ECG hallmark of the hypocalcemia is the QT interval prolongation, and as much as the prolongation happens, the more likely of arrhythmia. Usually, it is the common arrhythmia is torsades point, and if left untreated, it will be progressed to the VTAC and VFib. Other abnormality of cardiac changes in the ECG can be reduced voltage or negative T waves. In rare situations, can cause cardiac failure. So, for the history of past medical history, it's important to recognize the underlying cause. Here, just a few examples that can give us a hint. Like if this happened initially in childhood, that means we are talking about congenital causes. If there is a recent surgery of hand and neck, that means we are talking about post-surgical hypopara. If the presentation with abdominal pain, for example, and jaundice, it can be present as acute pancreatitis. And keep in our mind also the history of blood transfusion, massive blood transfusion. This can be related to the hypocalcemic cause. For the treatment, we need to divide it into a group: mild or severe hypocalcemia. Mild hypocalcemia, it is usually asymptomatic, and the level is more than 1.9. The severe hypocalcemia, either the level is below 1.9 or the patient is symptomatic, whatever the range. As we say, the symptoms of the hypocalcemia, it's not depend only on the level. It's depend on how rapid go down and how severe. For the treatment, usually you have to deal initially with the hypocalcemia as any other emergency. You have to decide about the situation in high dependency unit or ICU, and to start with the stabilization of the patient, ABC, especially, it's rarely, but it may have the laryngospasm with the hypocalcemia. The cornerstone of the treatment is the IV calcium. Usually the IV calcium should be given in hospital admission patients with the close monitoring every 4 to 6 hours. You can start with the stat IV calcium by 1 or 2 ampules of calcium gluconate, which is 10 to 20 ml. Usually the calcium gluconate elemental calcium, it is 90 per ampoule. Should be diluted in 50 to 100 ml of fluid, either dextrose or normal saline, and to be infused over 10 to 20 minutes with ECG monitoring. You can repeat this stat infusion while the patient is still have symptoms. This 1 or 2 ampoules will hold your calcium level for around 2 to 3 hours. So once you give this, you should think and start the preparation of the infusion of calcium gluconate. The preparation usually and the recommendation for it, it's to be 100 ml of 10% calcium gluconate. It's equal to 10 ampoule, diluted in 1 liter of normal saline, and to be infused in rate of 50 to 100 ml per hour. The other option is the calcium chloride. It is contain more elemental calcium. It's around 273 per ampoule, but this will be more irritating for the veins, and the calcium chloride should be given through central line. In the opposite, the calcium gluconate can be given through the peripheral or central IV line. If we did this preparation, which is 10 ampoule in 1 liter, that's meaning the concentration 1 milligram per ml of this 1 liter. And the calcium infusion should be 0.5 to 1.5 milligram of elemental calcium per hour. We can take an example just to make it easy as a calculation. If you have a patient with around 70 kg, that's mean if you give 70 ml per hour by this preparation, you will deliver around 105 milligram per hour, which is 1.5 per kg. So yeah, usually you can give the rate equal to your patient weight. And this infusion should be continued for 8 to 10 hours. If you continue to this hours, that means you will deliver around 15 milligram per kg. And usually this infusion will improve your calcium by 0.5 millimole. If you have recurrence of the symptoms of hypocalcemia, that's mean indicates you need to increase the rates or to give more boluses of IV calcium and look for the cause. Maybe there is underlying cause making resistance of the calcium infusion. Once you start the infusion, you should give the patient the oral replacement together with the IV calcium. Because you cannot stop the IV calcium infusion without effective regimen of oral calcium and vitamin D. Usually the IV infusion should be tapered slowly and over 24 to 48 hours with the adjustment of the oral replacement. We have certain situations that you have to be careful with the IV calcium infusion. The most common situation is the patient with digoxin as a medication. And in this situation, you will have high risk of arrhythmia. So you should be monitor the patient as cardiac monitors more frequently, and to make the infusion of calcium is slowly to avoid the arrhythmia. The second situation is the patient with hyperphosphatemia, because if you give a huge amount of IV calcium, it may lead to calcium phosphate deposition and metastatic calcification. Usually, this situation you can typically see it in tumor lysis syndrome. So treat the underlying cause first, correct the hyperphosphatemia, and the calcium, it will improve most likely by itself. You can give the IV boluses as a stat if you have risk of arrhythmia or QT prolongation. The same talk about the hypophosphatemia also with the patient of renal failure and acidemia. You need to be careful in this situation because you need to correct the hypocalcemia first before you correct the acidemia. If you did the opposite by correction acidemia first, that means the ionized calcium will be lower than the level of the patient he came with, and it will provoke the symptoms of hypocalcemia and specifically the arrhythmia. You have to keep in your mind two things while you are treating the hypocalcemia. The first one is the hypomagnesemia can be there and can be resistant to your treatment. So once it's happen, you have to correct hypomagnesemia first. Usually you can give a stat dose of magnesium sulfate of 2 grams diluted in dextrose over 10 to 20 minutes. You can repeat this if calcium not corrected, and you can go up to a higher dose of calcium infusion. Try not to give this magnesium infusion too rapidly, because this will cause urinary loss of both magnesium and calcium. So it will not help of correcting the hypocalcemia. You have to look also for the cause of hypomagnesemia. Usually, and we can see it in a lot of patients in ER, they came with high doses of BBI. So BBI should be stopped, or at least if you cannot, because of patient situation, to decrease the dose of the BBIs. The other one is the vitamin D deficiency. Once you have vitamin D deficiency, you have to correct this before the hypocalcemia. And in certain situations, you can give even the loading dose of vitamin D replacement. Oral therapy, we need it in two situations. The first one, the mild hypocalcemia, and in severe hypocalcemia as bridging to stop the IV calcium infusion. Usually it's oral calcium. We have many tablets and different elemental level of calcium. Usually,
Dr. Wael, you have 1 minute, please.
Almost, this is the last slide.
Sure.
So we have the calcium carbonate. You can give initially 2 tablets Q8 hour. Besides the vitamin D replacement, usually we prefer the active vitamin D. Calcitrol is the quick acting, and or alpha calcidol can give 0.25 to 0.5 microgram per day. This is the last slide. Just quick review through the approach and the treatment. So once you have the symptoms of hypocalcemia, as we mentioned, mainly neuromuscular symptoms, to give 1 or 2 ampules of stat IV calcium gluconate with the ECG monitoring. To repeat this IV replacement till patient is symptomatic free, and till you have the IV calcium infusion prepared. You can start the IV calcium prepared as we just talked about, 2 ampoules in 1 liter, and to start oral calcium replacement as possible as you can once you start the IV calcium replacement. This is for the acute hypocalcemia mainly. Hopefully, inshallah, it was covered nicely, and thank you for your listening.
Thank you, Wael. Well done. Nice approach to hypocalcemia, which is also a common scenario we are facing. As you said, there is more pitfall of management of hypocalcemia. Thank you again, Wael. Last speaker, our colleague, Dr. Nawaf Swaidan. He's a consultant endocrinologist in our department. He is on call for endocrine and diabetes today. So we'll ask him not to present his talk. You present what you have seen during his on call. Otherwise, he should talk about hypokalemia, periodic paralysis. Nawaf, go ahead.
السلام عليكم ورحمة الله وبركاته. السلام عليكم.
عليكم السلام. الصوت واضح.
تمام. الله يعطيكم العافية. Thank you, Dr. Dawish. I want to thank all my colleagues. They started before me. Hopefully my talk will be digestible, easy. I know it's rare, but we'll see how it goes. طيب, بسم الله الرحمن الرحيم. We'll talk about thyrotoxic periodic paralysis. So we'll start with the introduction. So it's a muscle disease in the family called canalopathy, manifested by episode of painless muscle weakness. These episodes may be precipitated by heavy exercise, fasting, or high carbohydrate meals, and it's classified as hypokalemic when episodes occur in association with a low potassium level, or hyperkalemic level when episode associated with the elevated potassium. Most of the cases are hereditary, usually as an autosomal dominant. Acquired cases of hypokalemic periodic paralysis have been described in association with hyperthyroidism. In contrast to other forms of thyroid disease, which are more common in a female, thyrotoxic periodic paralysis is much more frequent in male, and the prevalence is high in Asian population. This diagnosis should be considered when the demographic of a patient present with a marked paleness, weakness after a provocation of exercise or change in the diet. Now, just a few words about epidemiology. It's a sporadic form of hypokalemic periodic paralysis that occurred in association with hyperthyroidism. And in contrast with the familial hypokalemic paralysis, which is autosomal dominant inheritance. So just for anyone, if he didn't hear about it, there is two different diagnoses. There is hypokalemic periodic paralysis in the Asian population without thyrotoxicosis. And our thyrotoxic periodic paralysis is the sporadic form. The etiology of hyperthyroidism usually in periodic paralysis, including either thyroxine abuse or like other forms of hyperthyroidism, Graves' disease is the most common cause of thyrotoxic periodic paralysis, and also the rest of other forms of thyrotoxicosis. And it was widely reported in Asian population with the incidence of about 2%. In contrast with non-Asian population, the incidence of thyrotoxic periodic paralysis among individuals with hyperthyroidism is estimated to be 0.1 to 0.2%. And despite higher incidence of hyperthyroidism in women, over 95% of the cases occur in male. And the incidence particularly high among Asian with thyrotoxicosis, up to 13%. So what about the pathogenesis? What's behind this? So the thyroid hormone increases the tissue responsiveness to beta adrenergic stimulation. Along with the thyroid hormone, increase the sodium potassium ATPase activity on the skeletal muscle membrane. And also there is another pathogenesis, which is the insulin resistance with compensatory hyperinsulinemia, suspected to have a role in pathogenesis of thyrotoxic periodic paralysis. In one study, patients with a history of thyrotoxic periodic paralysis were heavier and exhibited reduced insulin sensitivity compared with the patient with thyrotoxicosis without periodic paralysis. Insulin also activates the sodium potassium ATPase pump and may act synergetically with the thyroid hormone to drive the potassium into cells. This is consistent with the observation that heavy meal can be precipitated of attack of thyrotoxicosis. So heavy carbohydrate meals will give surge of insulin release, will give more hypokalemia. And also there is a lot of genetic mutations. I don't like to bring them. And there is also a role of testosterone. That's why they said it's common in a male more than a female. So this is just a diagram about the pathogenesis, just to understand it very well. So the T4, in case of thyrotoxicosis, will synergize the adrenergic response on the ATPase channel. So this will give the intracellular potassium shift in the hypokalemia in the blood. So we will have hyperpolarization in the muscle membrane level. So at the end, the periodic paralysis. Also, the insulin release surge. So now we'll go to the main meal, which is the clinical features. So as with all periodic paralysis, attack of weakness occurs suddenly with generalized weakness and preserved consciousness. And the age of onset of the symptoms, usually between 20 to 39 years in approximately of 80% of the patient. In many patients, clinical feature of hyperthyroidism precedes the onset of the paralysis by months or even years. But also there is some report that periodic paralysis can present at the same time in about 60% of patients or following the development of periodic paralysis. So one is preceding the other. And the attacks are vary in frequency and duration. Interval of weeks to months are common, but some patients experience several attacks per week. Neurological examination during the attack demonstrate weakness, and the most important is to concentrate here. The weakness is proximal more than distal, and legs affected more than arms. And there is myalgia, and there is a decreased tone, so hypotonia and hyporeflexia. So it will be generalized weakness, but lower limb affected more than the upper limb, and it will be proximal more than distal. And when you assess the tone, there is hypotonia, and the reflexes is either hyporeflexic or areflexic. This is the typical presentation. In one series, tachycardia was noted in the presentation. This can distinguish between thyrotoxic periodic paralysis from the familial hypokalemic paralysis. And the duration of the symptoms of several hours is typical, but can range from minutes to days. As with hypokalemic periodic paralysis, attack in thyrotoxicosis precipitated by event associated with the increased release of epinephrine or insulin, both of which cause a movement of potassium into the cells and cause a low potassium level. So most commonly, the inciting event is either rest after very strong physical activity, stress, high carbohydrate load, or other event reported to induce attack of thyrotoxicosis like cold exposure, infection, alcohol intake. Last year, me and Dr. Wael, we admitted one patient in 2019 with a thyrotoxic periodic paralysis, and it was induced by alcohol ingestion. Also, pulse steroid amines can be a precipitating factor. Exceptional cases of bulbar weakness and respiratory weakness requiring ventilation also have been reported, but as well as a case of severe, even fatal arrhythmias can occur. In many instances, no obvious precipitating factor identified. Although the attack of weakness may occur at any time of the day, high-frequency attack, either in the night, early in the morning, has been reported, and seasonal variation also can play a role. More frequent attack in summer months, although the cold exposure also can be a precipitating factor. This is the diagram just to summarize the clinical feature. So adult young men, and it's a sporadic and recurrent acute paralysis with complete recovery. This is typical between attack, complete recovery. Lower limb more than trunk, precipitating factor, carbohydrates meal, salty diet, alcohol, or exertion. Family history of hyperthyroidism, clinical feature of hyperthyroidism, hypokalemia. You will find a normal acid-base balance, low potassium exertion rate, and also low phosphate exertion. If you do EMG, you will have a low amplitude compound muscle action potential with no change after epinephrine. This is if you want to do an EMG, but usually it's a clinical diagnosis. It's very easy to recognize the patient is classic thyrotoxic with paralysis. And here, just to distinguish between thyrotoxic periodic paralysis in the middle column and the right column between the familial hypokalemic paralysis without thyrotoxicosis. So the age and the male pattern more with the thyrotoxicosis, and thyrotoxic periodic paralysis is sporadic. The other one is autosomal dominant, and the ethnicity in Asian, the most common. and American, Indian, Hispanic, Caucasian, history of thyrotoxicosis, and also the clinical feature. So what can be also differential diagnosis we keep in mind, just to widen our mind, like familial periodic paralysis, could be idiopathic periodic paralysis, severe thyrotoxic myopathy, or even to keep in mind the Guillain-Barré syndrome, polymyositis, myasthenia, and also the rest of the differential. Laboratory-wise, we have the hypokalemia and the hypophosphatemia, hypomagnesemia, the thyrotoxicosis. And the treatment now start with the potassium supplement, but you keep in mind important that be careful from rebound hyperkalemia. So one prospective study compared the treatment with intravenous potassium to normal saline infusion and found a shorter recovery time with the potassium. And also the intravenous potassium recovered more quickly than oral route. And there may be a delay response of few hours following the potassium administration. So required doses of potassium supplementation are variable, ranging between 10 to 200 milliequivalent of the potassium. In one study, 80% of the patients, they develop rebound hyperkalemia. So we have to be careful because these patients, they don't have a problem with the potassium level, but their potassium shifted inside the cell. So most of the recommendation, patients better not to have a greater more than 90 milliequivalent of potassium within 24 hours. So like you can give a protocol of either 30 milliequivalent orally every 2 hours, or you can give easily 10 milliequivalent hourly, just to make it so easy. So 10 milliequivalent hourly, will be fine. So the patient need a close monitor of the serum potassium, cardiac monitor, because of the risk of arrhythmia, and you might consider to call your cardiology colleague and make sure that you have an ECG. And rebound hyperkalemia appear to be a prominent problem during the treatment in up to 60% of the attack. And don't forget to start either intravenous propranolol or oral one. And they recommend to receive a dose of 1 milligram of intravenous every 10 minutes, up to maximum of 3 milligram. Or you can give an oral, which is more easier, to give a 3 milligram per kg administered without the potassium supplementation alone. This one can reverse the weakness. Propranolol is a beta adrenergic blocker, can reverse the excessive stimulation of the ATPase channel and drive potassium into the cell. So just to summarize, in emergency therapy, and if anyone want to have a capture for this slide, so KCl 10 milliequivalent hourly as an IV, or you can give 2 grams every 2 hours and monitor the potassium level, avoid the rebound hyperkalemia, propranolol 3 milligram per kg orally, to prevent the recurrence, which is the most important. Avoid the precipitating factor, which is the most important. You have to explain to your patient until the euthyroid state is achieved, and you give him the propranolol every 2 hours, every 8 hours hourly, and determine the cause of thyrotoxic paralysis. And don't forget to treat the mother problem, which is the hyperthyroidism, with antithyroid therapy or radioactive iodine. How to prevent the attacks or restoration of euthyroid, which is very important, and also administration of the beta blocker, propranolol 40 or 120 milligram daily. You can divide them Q8 hourly. And the non-selective beta blocker, the propranolol should be given. It's likely to inhibit the beta-2 receptor mediated hypokalemic effect of epinephrine. So this can prevent the attacks. Potassium supplementation is not effective as prophylactic therapy compared to the propranolol and antithyroid medication. And also, the most important thing, don't forget to instruct your patient about the precipitating factor. The heavy exercise, high carbohydrates diet, salty diet, alcohol should be avoided. So here I can conclude with a home message that thyrotoxic paralysis is more prevalent in Asian population than non-Asian, male more than female, and the diagnosis made with the patient presentation of paralytic attack associated with hypokalemia and thyrotoxicosis. For acute weakness, which is not, patient is not responding to potassium administration, you can give the propranolol IV or oral as a 3 milligram per kg, or you can start the potassium and propranolol at the same time. And the attack of periodic paralysis will cease with the return to euthyroid state, and prophylactic propranolol can be also used until you achieve the euthyroid state. For a treatment of acute attack with severe weakness, administer the potassium, the KCl. Patient should be on cardiac monitor, potassium level monitor, and don't forget the rebound hyperkalemia. And the suggested protocol, you can give 10 to 15 milliequivalent hourly as IV with a maximum dose of 90 milliequivalent in 24 hours. And oral administration, if possible, also preferred. Here I conclude my talk. Hopefully it was easy, digestible. يعطيكم العافية.
Thank you, Nawaf. Well done. الله يعطيك العافية. أخذ من وقتك. You are on call. You are busy since morning.
يعطيكم العافية.
Well, thank you the audience. MashaAllah, we reach about 100 colleagues. They attend this sessions. We have a question on board here. We have 7 questions. I'll ask kindly, the panelist or the speaker to answer within just a few minutes because of time. They get, I think, exhausted. First question, role of IV fluid and insulin injection in a simple and complicated hyperglycemia. This is whether Balsam or Abdul Ghani. What's the role of uncomplicated hyperglycemia, giving fluid or insulin injection?
Thank you very much. I think it depends on the, I'm not sure about the question, but in acute conditions, if it is simple hyperglycemia without DKA or hyperosmolar state, you could just give correction of insulin without IV fluid unless the patient is having dehydration. The role of fluid, mainly whether in DKA or in hyperosmolar state, to restore the rehydration, to rehydrate, so to restore the volume. And the second thing, whenever you over you do diuresis of the glucose, so you excrete a certain amount of glucose in the urine, so it might contribute in lowering the blood sugar. But if the patient's having only just hyperglycemia, so you need only just to correct the glucose with insulin. I hope I answered the question.
Sure. Thank you, Abdul Ghani. Second question, how we can manage inpatient diabetic patient with diabetes on steroid? Would you like Maisa to comment or also?
Yes, actually, as I mentioned, that the topic was too long that I couldn't mention the details of the steroid. So regarding the steroid, it depends if the patient was diabetic or not diabetic. Either ways, usually steroid needs a high dose of insulin and the type of insulin that has a peak and has a long duration of action. So for example, patients who are females pregnant that are put on dexamethasone for premature labor, it's preferred to put them on, for example, MPH, which has a long duration of action. It has a peak after 6 hours, and it depends on how that patient is controlled with this dose. Either give him 1 dose or 2 doses. That's like one example as short answer. I hope I answered what you asked about steroid.
You mean depends on type of steroid, whether DEXA
Type of
or
steroid and type of patient, is he diabetic or not? We should think of a steroid that has a long duration of action, that has a peak, that can cover the hyperglycemia effect that comes from the steroid.
Sure. Thank you. We have a question here, and for Nawaf, in thyrotoxic periodic paralysis, will frequency attack will decrease the control of thyrotoxic state?
The frequency of the attack?
Yeah, will be decreased control of thyrotoxic state. That means if you control, I mean, the thyrotoxic
Yeah,
state.
I got the question.
Yeah, the potassium will be normalized by itself, or we need to give, other measures.
Yeah. Controlling the thyrotoxicosis is the main role of therapy. But if the patient presenting the acute attack, you cannot do that in, 1 hour or 24 hours. So yeah, to answer, yes, achieving euthyroid will prevent the attack. And also you should keep in mind, always educate your patient about the precipitating factor.
Okay, thank you, Nawaf. One question for Wael, but by mistake I deleted the question. They have a patient with autoimmune polyglandular disease who's having severe hypobara, require I think 6 or 8 mic of active vitamin D1 alpha. Celiac disease was screened as negative. He said what to do next as resistance hypocalcemia.
Yes. Usually the polyglandular autoimmune disease is difficult to control as hypocalcemia because they're associated with malabsorption either. But in this situation, if you reach the maximum dose of oral and you are sure about the celiac is negative and the patient is compliance, you have another option about the recombinant parathyroid hormone. It's effective in this situation. It can even decrease the requirement of the calcium and 1 alpha to 50% of the dose right now the patient on. But the problem with this medication is too expensive and I think is not available easily to the hospitals. I think either the 8 tablets, I'm not sure, is it 8 tablets or 8 mic? But anyway, you can go up with the doses even with more frequent Q6 hour either. More frequent, it's much better than higher doses less frequently. But for your question, I think what you can add, the recombinant parathyroid hormone. It's FDA approved. It's helpful to decrease the requirement of the doses, but as we say, it is not easy to be available and too expensive.
You mean the Netabara? Yeah, it's about costing maybe $1 million per year. Or what about teriparatide off-label?
Yeah, teriparatide off-label can be used as a daily injection. It can help also to reduce the doses. We use it as off-label, but I think still you will require high doses in these situations. It's difficult to control an ABS with malabsorption. Now we are talking about chronically, but if we talk about presentation, you should go with IV calcium for the acute situations. The recombinant and teriparatide, there is no role for this in acute situation.
Sure. Thank you, Wael. Question for Balsam. When can I say the patient is out of HHS and consider stopping managing the condition?
So yeah, this is a very good question. So HHS has many elements in it, as I mentioned. So you have the hyperglycemia, hyperosmolarity, and dehydration. So when you start managing, usually it is well known that you will take up to 72 hours to correct all the electrolytes and to restore hydration. So it is recommended that even if the blood sugar, with IV fluid hydration, and if needed to give insulin to lower blood sugar, you may keep the patient in for another couple of days just to restore hydration. So I would say the short answer to the question is, once you are sure that the patient has received enough hydration, you have reached an acceptable level of blood sugar, and you made sure that the precipitating factor that the patient entered with or caused this HHS is being treated. So these are the three components you should look into. And always keep in mind that HHS is different from DKA, because DKA usually patients improve within hours, but in HHS they may take up to 72 hours to go back to normal, or their baseline, let's say. I hope it's clear.
Sure, yeah. Also, one question can be answered by Maisa or by Abdelghani about correction dose, how we can do correction, how to calculate it. Is there any protocol for correction of the doses?
Yes, if you would allow me to answer it, if I'll tell you what I know. The correction dose, actually, it is put for two reasons. To try to figure what is the appropriate dose of insulin for for this patient, and also to normalize blood sugar before meals to bring it down to normal. So one of the ways to calculate the blood sugar, the correction dose for blood sugar, is to assume like we want before the patient eats, usually is given pre-meals. Before the patient eats his meal, we carb count the carbs in the meal, and that we calculate the insulin for the meals. But when we check the blood sugar for the patient, we want to bring it down to normal in order for the dose that was calculated from the meal to cover the meal. So there's an equation. It's fine. Like we subscribe. For example, the blood sugar is 250. We deduct that from 120 or 130. What's the ideal blood sugar, and the result that we get is divided by the total daily dose. We would get the insulin sensitivity factor, and from it we will calculate the correction dose. But I guess the question was, when do we give the correction dose? That's usually preprandial, to normalize blood sugar before the patient eats, and to make sure that the insulin that we calculated for the meal covered the meal, and the correction dose normalized the blood sugar. So after eating 4 hours postprandial or 2 hours, the blood sugar would come back to normal.
Sure. Thank you, Maisa.
Anyone would like to add a comment?
Thank you very much. It was really a good answer. Thank you.
Question for Dr. Abdelghani, that if patient blood sugar more than 400 going to the ER, questioning of DKA, but they get negative urine in ketones, and normal, maybe they say the EBG. He's asked about the rule, what to do in ER when I can't decide the patient safely to go home.
Okay, so thank you.
I mean, main hyperglycemia state. Yeah.
Yeah. So this. I mean, if the patient is presenting with very high blood sugar, but when we check their ketones is negative, especially type 1, which is commonly happen even in the clinic. What we need to correct for the hyperglycemia. So it's the same. So how to calculate for the correction? You do the insulin sensitive factor, dividing 1800 by the total daily dose. It will give you each unit will cover for reduced by how much glucose. So you do correction. You could do it every 2 hours till you reach the blood sugar, which is a safe one. You don't need to worry about to worry about the patient unless the patient is having a precipitating factor for DKA, which is a stressor like infection, or the patient is not receiving insulin. So what is important for the patient, like in type 1, to give them a basal insulin. So whenever you give basal insulin, you will suppress ketogenesis and lipolysis, so the patient will not go to DKA, and then you correct for the high sugar. When to discharge them from the emergency, it depends on the patient condition, purely that one. I mean, if the patient is not dehydrated, he's not having infection. Just a matter of like eating a lot of carb, and he came with hyperglycemia. Just correct for the hyperglycemia or give him the insulin and let him go to the diabetes center for follow-up. And I hope by this one I just answered the question.
Sure. For Nawaf, does level of hypokalemia give a clue between familial versus thyroid causes?
First of all, I want to say hi for my brother and friend, Dr. Hakimi. Just to answer this one, no, the severity of hypokalemia will not differentiate between the hypokalemic paralysis and thyrotoxic paralytic paralysis. The clue here is the thyrotoxicosis, clinically and biochemically.
والله ما انتبهت لاسمه. مرحبا الحسين، يعطيك العافية. كيف الجنوب؟
We miss him, والله.
Yeah, sure, definitely. I think there is one question. I don't know who will answer this one for who is on a keto diet to lose weight. What about the urine dipstick in young people? I mean, maybe they are worried about is he going to diabetic ketoacidosis or who's diabetic patient. And this is also a common scenario nowadays. They want to lose their weight, they will go to keto diet.
Okay, shall I answer?
Yeah, please go ahead.
Yeah, so for type 1, it's not advisable for them to go to keto diet. The problem with the keto diet, they will deprive themselves from carbohydrates, so you cannot give them boluses insulin. They will be dependent on basal insulin, and they will be really at very high risk of getting diabetic ketoacidosis. For the patient with type 2, if they get some insulin reserve, it is okay to go for a ketogenic diet, but they have to be careful, and I think they need to check their ketone level frequently. And the problem with the ketogenic diet, they go on high fat, high protein diet. So the high fat diet is not really advisable for patients with type 2 because there is increase of they get like some sort of dyslipidemia associated with their diabetes. For a normal person, if they are going into ketogenic diet, they have to have like an excessive water intake. They should monitor their urine output. In addition, the ketones will be present in their urine, because that is the result of from depriving themselves from the carbohydrate. But what they should monitor their urea and creatinine and the level of hydration. And if there is anyone who would like to add.
Okay, thank you, Abdulghani. I think we have the last two questions, one for Balsam and one for our colleague Ms. Basma from postgrad or education department. Balsam patient who's like an MDI, if he's going to be MBO, what to do with the Lantus? Do you need to give Lantus? I think maybe they worry about to go to DKA or hyperosmolar.
Sorry, the question is if the patient presents to the emergency room with one of the diabetic emergencies, meaning DKA or hyperosmolar, what should you do about the Lantus? Is this the question? So if this is the question, what I know is there is what I would answer is with there are two approaches. One approach is to immediately on presentation give either half or full dose of long-acting insulin, and that's a safer option. This is the UK approach. I find this to be more useful, more beneficial, more practical, because in case you need to stop the insulin infusion, like in cases of hypokalemia, you're sure that the patient has insulin on board, and it makes shifting from IV to subcut easier. Whenever the patient is out of DKA, the American approach usually recommends that you continue with IV insulin, and then without giving long acting until the patient is ready to eat and is out of DKA. Then you overlap for 2 hours over a meal, and then you stop an insulin infusion. I hope this is a question and I answered. And I don't know if Dr. Abdulghani has another comment to add.
Thank you very much. It was really a good answer. Thank you very much, Balsam. But I think, just the key message here, in any patient with type 1, never stop the basal insulin. Otherwise, you might drive patient to go to DKA, even if they are, going to be inpatient. Actually, in one approach, in treating them while they are having diabetic ketoacidosis, to continue with their basal insulin and give them the insulin infusion.
Yeah, can I just add one point? It's most societies and most practical life, sometimes, even if you know that the insulin infusion preparation will take time, it is recommended to give the patient like a bolus subcut insulin, even if you can't have the long acting, because short acting is available, easily accessible. So if you are concerned that the insulin may take time to come, it's better to give the patient short acting subcutaneous insulin, just to be safe.
Dr. Dweesh, I think maybe Dr. Dweesh he lost the connection.
Yeah, is it clear now?
Yes, it's clear.
Yes, Abdulghani, a quick question, quick answer, please. Hemodialysis patient came with severe metabolic acidosis, also as decay as well. How to treat, just as outlined, the decay in hemodialysis patient?
So the diagnosis based on serum ketones. So we need to do the serum ketone for the diagnosis. Management of DKA, what we will provide as a diabetologist or endocrinologist, will provide them with the insulin infusion, and then we'll tell our colleague from the nephrology department to take care, because these patients, the treatment for them to do hemodialysis and even about the potassium supplement, we'll leave it to the nephrologist. So what the diabetologist will provide, only insulin infusion.
Thank you, Abdulghani. So, Miss Basma, يسألون عن الماتيريال كيف يحصلون عليها? Is it copyright to you as a department? كيف يحصلون على المحاضرات هذه؟
أيوة دكتور، موجودة على اليوتيوب على قناتنا، راح أنزل الرابط. هي قناة Continuous Education. أي بوستر أو إيفنت لنا، مجرد ما يسووا سكان QR كود راح يوصلهم على قناة اليوتيوب.
طيب ما علمتونا في مونتاج، ما في مونتاج ولا؟ إحنا
نسوي المونتاج، إحنا نضبطها. حاليا المحاضرة هذه تم نقلها لايف على اليوتيوب، وبنفس الوقت يعني أي أحد يعني بكرة وبعده ممكن يشوفها أي وقت.
بعضنا ما شخص، بعضنا ما خفف الشيب. الله يهديكم بس.
والله فيكم الخير والبركة دكتور.
أعطيكم العافية. شكرا بسمة، شكرا كل الأودينس، شكرا على حضوركم معنا، ونتشرف فيكم بكرة إن شاء الله بالليل. والتراي اونلي نفس الطريقة هذه، ساعة ونص بالكثير إن شاء الله. في البداية جسد توكس على غدا إن شاء الله. يعطيكم العافية، تصبحون على خير.
Thank you very much. Thank you.